Yeah. Is it visible for everyone?
Yes, sir.
Okay. So, good afternoon, everyone. Here, before starting the session, I just wanted to tell you a few things. One thing is that I kept my slide very simple. It's very simple so that because as the course is a foundation course, I don't want foundation, I don't want to make it complex. So I make everything is very clean and clear and very simple language. And so that is one. Second thing, if you are facing anything, any problem or anything you need to be repetition, then you just note it down somewhere. At the end of the session there will be little bit of time so we can address those things. Third thing, I want my session to be little bit interactive because as you are not in front of my eyes, so definitely I want your response. Of course I cannot talk to like a wall or something without without any response. So thank you so much, and definitely I'm starting. So my slides, there will be little repetition for you people. I think it will be good for you only, so it will be revised. So I think in pain management one, you have all of come across that the principles of pain management. It should be the by the clock. That time to time we need to give the pain medication. There should not be any kind of bias. Then by the ladder. So whatever the pain management medication we are giving, so the doctor also have to give it nicely, and the sister or nurses, those who are going to administer, they need to have knowledge properly so that the same class drug should not be repeated. Next, by the class, so whatever the class, that is the WHO analgesic ladder steps, whatever the steps we are using, it should be used, and the same two class or same class drug should not be repeated many a time. Then attention to the details, like whenever we take any kind of information from the patient, so we should try to listen them because they must have some problem. Like whenever we ask them that this medication you have to take in like just after food or after having your meal, so maybe the patient may have like Monday they used to, some of the people they have fasting for Mahadev and all those things. So if they are fasting, they think that okay, if we are fasting and if we take the pain medication, there might be some issues, there might be some problem. So better not to take the medication. So that's why if there is, they are come up with that like increasing of pain, we need to listen them. What are the details behind that? We need to take the history properly. Next, I think you all have come across this WHO analgesic ladder. So actually the ladder has the four steps, but in palliative care, the fourth step is interventional pain management. But in case of palliative care patients, they does not have that fitness to undergo any kind of procedure to reduce the pain by nerve block or any other procedure. So that's why in palliative care, we widely use three steps only and four steps, but it's there in the WHO analgesic ladder, of course. If we see the like what are the step one drugs, can anybody tell me? It will be a revision because you all have the class regarding that. You can put it in the chat box, of course.
Dear participants, please respond.
What are the medication under step one? Yes. If you are feeling shy
Uh,
to tell me, you can put it in the chat box.
they kept in chat box diclo, PCM, then ondan.
So, okay. If we see that step one drugs, it will be paracetamol, ibuprofen, all kinds of NSAID, non-steroidal anti-inflammatory drugs like diclofenac, aceclofenac, eterocoxib, all those, and antispasmodics also comes under step 1 drug. What are the nurse's responsibility? Like if the patient is having any kind of hepatic problem like liver lesion, so we should try to avoid paracetamol. If they have any kind of stomach upset, we try to avoid NSAIDs. If they have any kind of kidney related problem, we try to avoid NSAIDs as far as possible. If they have any kind of bleeding disorder, bleeding is happening, so we try to reduce the like the NSAIDs consumption. If we see that step 1 drugs, so there are tramadol, tapentadol, codeine and oxycodone. There are 4 nurses responsibility mainly. Like step 2 drugs are certain limit. So I think the whatever the class taken previously, they have already explained that tramadol have certain limitation. We cannot go up to more than 400 mg in 24 hours. So the drug we need to be in limit. Next, two step 2 drugs should not be given at a time. Sometimes it happens that patient was taking ultraset tablet where tramadol is there. In the same time, patient complain about severe pain. We have given injection several times, but we nurses forgot to mention that they don't have to take this oral medication. So they are taking oral medication, in the same time they are getting injection also. So there are two similar drugs they are getting at a time. This should be avoided. Next, step 2 and step 3 drugs should not given at a time, because both the drugs works on same receptor. So if they works on same receptor, there is a possibility to uh, like pain management should not be like adequate pain management will not be there. Next, step 2 drugs should not be used for children below 12 years of age, because their liver and their kidney is not matured enough to metabolize those drugs. So in case of pediatric, the step 2 is not there, so we need to avoid that. So either they will get NSAIDs, or if it is not effective, they will directly go to the step 3 drugs or strong opioid. So but in some cases, if they have any kind of hypersensitivity with the morphine or fentanyl, if the like institution does not have the license to procure morphine or fentanyl, in such case we can give tramadol in SOS basis, but under observation, of course. We cannot give tramadol for continue doses. Now, which step we should use in which situation? So depending on the severity of the pain, in case of mild pain, we can use step 1. In case of moderate pain, we can use step 2. And in case of severe pain, we can use step 3 drugs. So today's topic was step 3 drugs. So I'll just try to go back to my WHO analgesic ladder. Okay. So step 3 drugs, also known as opioid. Step 2 also known as opioid. But step 2 is weak opioid, whereas step 3 is strong opioid. So what are the drugs? Can anybody tell me? Yes?
Fentanyl, they put it in chart box. So, Stangen. Stangen gave the
So
answer fentanyl.
okay, so there are 4 drugs: buprenorphine, morphine, fentanyl, and methadone. So we will be discussing about 4 of them. So there are some nurses' responsibility while we give the step 3 drugs. So one is repeated reassessment is required, so that we can give the required dose to the person. Next is family teaching is very important. So we have to understand the family dynamics. Who is the caregiver with the patient most of the time, then in that case we have to explain that family members or that relatives only, or that caregiver only. Otherwise, if I explain to some other, because whenever patient came to the hospital, you will see that 5 or 10 person will come all together while patient are coming for the admission. But when time gone, then after 3 4 days you will find that 1 or 2 people close to their relatives or close to their family members, they are only staying continuously with the patient, but others they have left the patient. So in such condition, if I explain some of them who left already, so of course the explanation will not be effective. In that situation, I have to understand the family dynamics, to whom I should explain, who is the actual caregiver to the patient, I have to explain to them only. Next, ensure the patient is getting stimulant laxative, because the strong opioid and weak opioid, both the things works on central nervous system. When it works on central nervous system, it reduces the gastric motility, and because of that patient develop constipation, and because of that they need the stimulant laxative. Not only the simple laxative, they need the stimulant laxative, which will increase the gastric motility, of course. Next is, when start first time, they might have little bit of side effect like nausea, vomiting, universal side effect, and some case, in case of morphine or fentanyl, they might have little bit of drowsiness or sleepy. This we have to explain to the patient that it needs 5 to 7 days to adjust with the patient. If it is remaining the same even after 5 to 7 days, they must inform to the hospital or doctor. Next, step 2 medication should not be used at a time. So that in that case also, the previous slide I have explained that step 2 and step 3 should not be used at a time, so that they both of them they works on the same receptor, so there will be agonist antagonist effect. So like it like agentship. So we our body have receptors. So if tramadol is having the tie-up with some of the receptors, on that receptors morphine cannot work. So if morphine is bonding, making bonding with some of the receptors, tramadol cannot work. So because of this effect, there will be the pain relief will not be adequate, there will be agonist antagonist effect. So that's why step 2 and step 3 we should not use at a time. If the patient is transferred from the tablet to the patch, in some conditions, first 12 hours of dose should be given by the previous medication, because if we give any kind of transdermal patch, it takes 12 hours to comes in the blood plasma and maintain the baseline pain. In such condition, immediately after starting the fentanyl patch, if we stop the morphine, then patient might have pain for 12 hours. So in that condition, we suggest to give 3 more doses. If we give the morphine 4 hourly, that means 3 more doses after even like putting the transdermal patch, so that the baseline pain will be maintained, patient won't be suffer. Again, I just wanted to show you the chart. So, non-opioids like paracetamol, ibuprofen, diclofenac, that all I have explained. Weak opioids like tramadol, codeine, and oxycodone. Strong opioids are morphine, fentanyl, buprenorphine, and methadone. There are, if you see the WHO analgesic ladder, in every step it's mentioned that plus minus adjuvant. What do you mean by adjuvant? Can anybody tell me? I'll be very happy if you can tell me.
Please respond, guys.
Yes? What do you mean by adjuvant? Okay. Uh, like if you are finding any problem, so I'll be telling you. So adjuvant is the drug. which does not have directly affect on the pain, but it increase the efficacy of the primary drug. Suppose I will give you an example. Uh, See, a ovary patient came to you with huge abdominal mass, and because of the compression of this mass, okay, then the person, the lady cannot pass stool, and because of that, she is having abdominal pain, because cramping pain something. So you have given morphine, you have given Buscopan, antispasmodic, but still the patient's pain is not subsided. We have increased the dose of morphine. She is getting drowsy, but still pain is not subsided. So in such condition, doctors give corticosteroid. If we give high dose of corticosteroid, what happens? Steroid has that anti-inflammatory property, and because of that, peritumor edema, somehow it shrink for a little period of time. If it shrink for a little period of time, so flatus will get the place to bypass, and because of that, pain might be reduced. So here corticosteroid has no effect on the pain, but corticosteroid helps morphine to increase its efficacy by helping him that shrink the tumor for a shorter period of time. So again, if I give an example, anticonvulsant drug. If you see that palliative care and pain management or pain clinic, we widely use pregabalin, gabapentin. If you like Google on the, or if you see your drug book, so gabapentin is a anticonvulsant drug, but it blocks the nerve impulse, and because of this property, it also works on the neuropathic pain. So we give neuropathic pain component to increase the efficacy of primary drug, maybe tramadol, maybe something else, but neuropathic component, if it is there, then anticonvulsant will work more. So gabapentin will reduce the neuropathic component. By the same time, if there is any primary drug, so primary drug efficacy will be increased and there will be good result. In the same time, if you see that antipsychotic, antidepressant, so SSRIs, tryptomar, some of you, if you are working with palliative care, you might have known that we use tryptomar or amitriptyline tablets, amitriptyline 25 mg, 10 mg to address the neuropathic pain. In the same time, it also blocks the thought of the patients, like it works on NMDA receptor or NMDA neurotransmitter. Because of that, the antipsychotic and it also known as SSRI, selective serotonin reuptake inhibitor. In the same time, so you must have come across the concept of total pain. In case of palliative care, it says total pain, that it has the physical component, psychological component, social and spiritual as well. So WHO analgesic letter only talks about physical pain. It does not talks about any other component of pain. So here, if we use the SSRIs, so SSRIs will address the antipsychotic component of like psychological component of pain, and by that time the pain will be addressed more effectively. So now we will discuss about little bit of buprenorphine, little bit of methadone, fentanyl and morphine. Okay. So buprenorphine comes in the form of patch. It comes in 5 mcg per hour patch and 10 mcg per hour patch. Also it's available in the name of Adnoc tablet. So it's a 7 days patch. So whenever we put any patient this patch, we have to put it for 7 days. We have to ask the patient to keep it for 7 days. It of course a water resistant or like waterproof patch, of course. In the same time, patient can take bath. That one we have to explain nicely. Otherwise, some of the patient that if we put the patch for 7 days, the whole 7 days they never take the bath. So that's why we have to explain it that with that patch the patient can but take bath. That is one. Second thing, the advantage is They does not have to take the medicine on time because it's in the skin, it's transdermal. Every time it's releasing the buprenorphine and pain relief is adequate, so they do not have to worry about their tablet timing and all those things. This is the most uh, main advantage, but disadvantage also is there. One thing, if there is any kind of emergency pain, like what to say, SOS pain, or if there is any kind of like breakthrough pain, we cannot give any kind of bulas from the patch because it will be definitely released in a particular manner. We cannot change it. That is one disadvantage. Secondly, as it is as a 7 days patch, in the summer season patient might have sweating. Because of that, sometimes they will experience that after 3 4 days it will be automatically coming out, so the efficacy of the patch will be very low and pain relief is not adequate. Thirdly, they will find that, okay, some of them they might find that in the transdermal area where we have putted the patch, so this area they might have some skin rashes or something else. Thirdly, if the patient have any inflammatory process in the place where the patch has put it, or he or she has having continuously repeated fever, because of the fever, like blood flow will be increased because of the temperature, and when the blood flow will increase, then they will absorb more buprenorphine from this patch. So ultimately there is a chance of having this side effect more. So these are the advantage and disadvantage. And also buprenorphine has the positive and negative effect at a time, like agonist and antagonist effect. So in some cases it works nicely, in some cases it is not effective at all. So we even do not know in which cases it will be more effective or it will be less effective. So because of that, and this patch is very difficult for the patient to maintain, because of that buprenorphine we never use, or like we are not using very widely. But of course those who can definitely maintain or through counseling we can give. If we see the methadone, methadone comes in the tablet form and syrup form. Methadone works on mu receptor, methadone works on NMDA receptor, methadone works on SSRIs. So methadone is not only works on physical component of pain, but also there are some effect on the psychological component as well. So NMDA receptor blocks our thinking of physical thought of pain. Na? If you are going to give IM to someone else, so whenever your patient is seeing that you are coming with a big needle, so they will just close their eyes thinking that I am going to get so much of pain right now. So this thinking, by thinking of that, the patient is suffering with pain or getting the pain. So in that condition, so NMDA receptor blocks that thought. So they cannot think. That is one. SSRIs works as a antipsychotic and anti-depression. So the psychological component of pain it address, and mu receptor works on the physical component of pain as well. There are some disadvantage. So advantage is very nice that it is more effective than the morphine and fentanyl. Thirdly, it is very widely using in some of the centers, and if the patient has their no other cardiac conditions, then we can go with methadone, of course. But there are some disadvantages that the syrup, those who have that policy that you are not dispersing the methadone in the name of patient, you are keeping the it in your control, so it will be difficult. Like methadone syrup, it's like a cough syrup and it's getting dry in the mouth of the bottle. So whatever they are writing, that 100 ml or maybe 150 ml, this 150 ml you are not going to get properly. So because some of the things, some of the medication, it will be spoiled, it will be get dried. So ultimately FDA people, it will be create problem that, okay, itna this many dose where it gone, so you cannot predict that. So there is one disadvantage. Second disadvantage, in maximum of the palliative care patients, they are not fit at all by cardiac condition, that we cannot give methadone to every patient. And thirdly, if we give that methadone to the patient, we have to definitely keep them in track, so that methadone should not be misused in the same time, because sometimes what happen, we should explain the patient nicely. Methadone have the tendency that first 5 to 7 days or 10 days, the methadone get absorbed in the subcutaneous tissue. So, and after 10 days, it starts releasing from the subcutaneous tissue. In the same time, when it getting absorbing in the subcutaneous tissue, action will not be properly, we are getting it for the patient. Like pain relief will not be adequate. If we think that, okay, we will give the more doses, then if we increase the dose, by the same time, if subcutaneous tissue also start releasing, then it will be very difficult for the healthcare personnel to manage. That's why using methadone needs an very much trained personnel and trained doctor and nurses as well. So that's why methadone also not widely used in many of the centers. Let's come to the fentanyl. Fentanyl is available in the patch form. Fentanyl is available in the injection form. Some of the centers, they have the fentanyl in the lollipop form also. So basically fentanyl is a 72 hours patch. If it is used in the patch form, it starts from the 12.5 mcg up to 100 mcg patch is available. So fentanyl patch, it's an very costly, and fentanyl, like it's a 3 days patch. Again, for the patient, it's difficult in the summer season to keep in their body, because it's getting sweating, and uh, easily it's getting out. Sometimes because of the not properly placed it properly, then bubbles will come, bubbles will form in between the patch. So ultimately pain relief will not be adequate, or pain relief may not be adequate because of this, and because it is not cost effective. So ultimately fentanyl also, most of the centers, they are not using very widely, but some of the cases we need to use. Like one thing, if the patient is a older people, they cannot remember every 4 hourly they have to take the medications. So in that case, and the patient is already in the set dose of morphine, we can convert it to the fentanyl, we can give the patch. And by the same time, so we have to give them good health education on the information, that every time they should come to the center or go to the nearest center to change it. You cannot give them in their hand, because there is a one incident happened with me only, because in our center, so I am taking the responsibility. So what happened, we have given fentanyl patch, doctors advise 50 mcg patch to put. So I have put it 50 mcg patch. By that same time, I have asked them to take 3 doses of morphine, whatever they were taking before. So they have taken. After one day, they realized that after putting first patch, half pain gone. So they immediately open the second patch and put it in the other part of the body, so that they imagine that if I put the double patch, then the whole pain will gone, and pain relief will be adequate. And after 3 days, the patient came, went, actually for patient went in wheelchair, but patient came in stretcher. So this is one disadvantage with the fentanyl, because fentanyl is 100 to 125 times more potent than the morphine. And also fentanyl is a synthetic mu agonist. man making. This is man making. So because of that, it fentanyl only works on mu receptor, and because of that, in case of metastatic patient, if they have bone metastatic, so it does not have any effect on the bone mats or bone pain. Because of that also, it is not cost effective also. It is very difficult to maintain. So that's why we try to avoid as far as possible. There are some nurses responsibility. What is, like, if the patient is already on patch, he or she came to the center to change the patch, what we need to do, one is reassessment is required. These 3 days, how was your pain? Was it like tolerable, or is there any history that the pain was increased, and what you have done in the same time? Next, detail history and if anything unusual happened. Next, ask if the patient took bath or not. Like, if patient is getting fear, like patient is fearful that if I take bath, then the patch will get removed and pain relief will not be adequate. So in the same time also, we should not give patch because it is creating burden for the patient in daily living activities. Why to use that then? Next, do not use any inflamed area. Sometimes patient feels that, okay, I have pain in that area, so please put your patch here. So by that same time, we should not use in the place where there is inflamed, where there is high temperature, or during the fever also we should not give the patch, because of the temperature, blood vessels become dilated and blood flow become more in that particular part, so ultimately absorption of the medication will be more and there is a high chance of getting side effects. Next, how many extra dose of morphine? If we are giving fentanyl to the patient, if I am giving fentanyl first time, in the next visit, of course, I have to take the detailed history that in that 3 days, how many extra doses of morphine the patient has taken. So because of that, I have to address this, and if required, dose may be increased. We need to increase the dose. Otherwise, if I put the same strength patch, their pain relief will not be adequate. But in the same time, we have to remember that never ever they use those painkillers for other members of the family. It also happened in our hospital. One old man came with his wife every time, and we have given morphine. Okay, so we have started with half morphine Q4H. So he realized that after taking this half tablet, his pain gone, that 90% pain gone. In the same time, his wife, this old lady, is having back pain. Then he realized that, okay, if this half tablet can completely cure or completely like reduce my pain, it also can reduce your pain also. He has given this half tablet to his wife, and next day, till next day, she didn't wake up. So this is the history, that it is because of the poor management of the medication. So we nurses has to take the lead, and actually experience comes with this kind of incident only. So these are the things make us knowing that what are the things we need to keep in mind while giving morphine, while giving fentanyl. So these are the things we need to keep in mind. So next come to the morphine. Morphine are available in the tablet form and injection form. You can see the two color, two different color tablet. So this Varmer 10, it's a IR tablet, instant release tablet. You can see morphine sulfate tablet 30 mg. It will purple coated. It's an SR or extend release tablet. So and injections comes in 1 ml vial, 1 ml ampoule, which consists of 10 mg. So IR tablet, it works start working within the 45 to 60 minute and works for 3 to 4 hours. That's why IR morphine, whenever we give to the patient, we tell them to take it every 4 hourly to maintain the baseline plasma level and baseline pain. Next, if we give the SR tablet, sustained release tablet, it comes in action within 90 to 120 minutes and it acts for 8 to 12 hours. So in that case, we can give BD or TDS. Suppose any patient, if the patient is getting, suppose you have 30 mg SR tablet, you have one patient who is getting 10 mg morphine, IR morphine 4 hourly. If we give 4 hourly, that means in 24 hours we give 6 doses. If we give 6 doses in 10 mg, that means 60 mg in 24 hours. But in the same time, if we change the patient from IR to SR, we will give 30 mg BD because it works for 12 hours, 8 to 12 hours. So we try to give 30 mg SR BD, but in the same time we have to give IR as well, because if there is any kind of breakthrough pain in between, suppose morning 8 o'clock the patient took the first morphine SR, next he or she will take evening 8 p.m. In the meantime 1 p.m. he or she is having pain. What he will take? He will take 10 mg IR tablet, because again if he takes any kind of SR tablet, so it will take 90 minutes. That means 1.5 hours to 2 hours to act. By these 2 hours, the patient will go crazy, patient will suffer. So we will try to give IR in the meantime. Next, if the patient, I will give and one more example. If the patient is having 15 mg morphine, IR morphine 4 hourly, 6 dose will consumption 90 mg. In 24 hours, he will take 6 doses. If 6 doses, then 15 mg into 6 doses, 90 mg. In that condition, if I try to give them SR, then I might give 30 mg TDS, because it also works in 8 hours also. We can give 8 hourly. So 30 mg SR can be given. In the meantime, we have to give 15 mg IR for SOS pain. Because SOS pain, we cannot give one more SR. We have to give IR only. So there is little bit of formula. I will not go with the very details because there is no point of going details. You have, some of you have even not seen the injection morphine. So there is no point of going the details. So there is a formula that oral, subcutaneous and IV. Whenever we convert morphine, this is a conversion for morphine only. So whenever we convert from oral to IV, like oral medication will be always the high dose. If we are giving directly to the intravenously, that means the dose has to be little bit lesser dose. So if we go from oral to IV, the dose will be divided by 3. If we go IV to oral, it will be into 3. If we go to oral to subcutaneous, it will be divided by 2. If we go subcutaneous to oral, it will be into 2. You just need to remember that, because it's necessary for your morphine trial. Next, come to the morphine trial. When we give morphine trial, so basically given to the patient who has poor control on the pain with step 1 or step 2 drugs. Next, this is to understand the morphine requirement of the particular patient. Sometimes it happens that we have given morphine and caregiver change and they are giving morphine not on time. So ultimately the patient came on pain. If we are asking that, whenever we ask that, did you take the morphine on time? No, I didn't take. Since last 2 days I have not taken. How can I realize that the whatever doses we have prescribed before, it was the particular correct dose for the particular patient? we cannot find it in the OPD. So in that condition, we can go for morphine trial to find it out the required dose. Next is it helps the patient to get immediate relief from the severe pain. How to the procedure? So assess the patient's pain severity in an appropriate scale and record it in a nurse's note. So we need to remember that if I assessing a patient, every time I should use a particular scale only. Like I am on duty, I am using numerical rating scale. Anusha madam came and she is using Ohm-Baker scales. Of course, for both of us, result will be different. We have to use the particular similar scale for every time for this particular patient so that we can compare the efficacy of our painkillers. So we have to assess the pain. If the patient, suppose, if the patient tell that I am having pain like 7 by 10 in numerical rating scale, that means the patient is having severe pain. So and I have explained that injection morphine comes in 1 ml and it comes in 1 ml equal to 10 mg. So 1 ml injection we will be diluting in 9 ml of NS. Ultimately 10 ml and 10 mg. So 1 ml equal to 1 mg solution we made. In the same time we will take one more syringe with normal saline. We will give every time 1 ml 1 ml. Every 5 to 10 minutes interval we will give 1 ml 1 ml, and after giving 1 ml of injection morphine we will give little bit of saline, otherwise the whole injection will not go in the bloodstream. Some of the things, some of the little bit of your injection morphine will be in the cannula or your three-way cannula. So it will be very difficult for you to understand the efficacy. So every time you give the injection morphine 1 ml, you give flash so that everything gone to the bloodstream. After 5 minutes, 10 minutes, you just reassess till the time. Our target is two things. One is till the time patient's pain become 3 by 10 in numerical rating scale or patient become drowsy, whichever is earliest. So आप whenever you buy a new motorbike, so उसमें लिखा होता है say fast servicing will be either 500 kilometer or 1 month, whichever is earliest. So here also it's the same. So either the pain relief up to 3 by 10 numerical rating scale or getting drowsy, whichever is earliest. In that particular point when the patient is getting drowsy but pain is 5 by 10, we will stop. If the patient is not getting drowsy, then I will go up to 3 by 10. Suppose पेशेंट को मैंने 4 बार 4 times 1 ml 1 ml 1 ml 1 ml 4 times after giving, then patient came from 7 by 10 to 3 by 10. This is noted. Okay, so this is the 3 mg or sorry 4 mg of IV morphine makes the patient stable. If I convert the morphine to oral morphine, that means 4 into 3, 12. 12 mg of oral morphine I have to prescribe to the patient. If we feel that we are not confident or patient is going to go at home, we can start with 10 mg of morphine and 10 mg SOS. We have to ask the patient to come after 3 days, and in this 3 days how many SOS dose he has taken we have to chart it, and accordingly after 3 days we have to set the dose. That is for OPD patient. If the patient is IPD patient, then we can go up to 15 mg but under observation, because it's coming 12 mg 4 mg IV morphine make the patient stable. That means if I make it 3 into, that means 12 mg of oral morphine. 12 again I have to make the tablet in 1/4, then it will be difficult. So better to give 15 mg, 1.5 tablet. If you have 10 mg morphine available, 1.5 tablet, but under observation. Let's see if the patient is getting drowsy, then I will make it 10 mg, of course. So this is all about the morphine trial. Morphine trial to make understand what is the patient requirement and what we need to give. Now, आप लोगों का मन में, in your mind, it might come that if I give more morphine, then patient might have addiction. Try to telling you that addiction and pain cannot happen at a time. If the patient pain has already been managed, after that blood plasma level, this morphine is remaining in the blood plasma level, it can make addiction. So that's why never ever we target to reduce the patient pain from severe to make zero. Our target is always to make the patient pain in bearable status. It's always 3 by 10 or 4 by 10. We never ever try to make the pain zero. If we try to make the pain zero, ultimately we have to give more morphine, and more morphine will make cause this addiction, and later on he or she will come up with some other problems. So these are the things need to be keep in mind. Come to the side effects. So if we see the side effects, nausea and vomiting is an universal side effect, you all know. Constipation because of the morphine, that because morphine or any other opioids, it works on central nervous system, so it reduces the peristaltic movement of the patient. So ultimately because of that patient develop constipation. It is the like mostly common side effect of the opioids. Sometimes it causes itching, and many a time it causes urinary incontinence. Some adverse effect like drowsiness, delirium, respiratory depression, meiosis or myoclonus. It's very difficult to keep in mind. So that's why there is another system to keep in mind. We all are having our sacrum bone. So just remember your sacrum. S means sedation, sedation or drowsiness. If the patient is having more drowsy, we should reduce the dose. That is one. A means analgesia. Of course, we are giving any kind of analgesic effect to get the analgesia effect. But if it is more than the expected result, we need to reduce the dose. Suppose patient was getting tramadol 100 mg tablet TDS. Accordingly, we are trying to start one tablet morphine, one tablet Q4H. Under observation, patient came to OPD and we have given one tablet from our stock. And then after taking one tablet, patient was telling, "Oh my God, whatever the medicine you have given, it was very nice. Now though I do not have any pain only." So it is a alarming sign for me that the same dose, if I continue, that the person may have developed any kind of side effects. So here we should reduce the pain or increase the, decrease the frequency. Maybe 4 hourly, not 6 hourly we can give. Maybe we can decrease the dose up to 5 mg or 5 mg SOS at the same time. Constipation I have already explained because of central nervous system and reduce gastric mortality. Because of that we need stimulant laxative. So there are four kind of different laxatives are there. So there is one kinds, like one category, it's called stimulant laxative. So either bisacodyl is the drug of choice. If the patient cannot take tablet, patient is on Ral's tube, so cremafin plus or with the syrup which has the property of sodium picosulfate. Sodium picosulfate is the property which causes stimulant effect of the laxative. So basically cremafin and cremafin plus, two things comes. Normal cremafin he is having liquid paraffin and milk of magnesia, which works on only make the heart stool as a cream, but it never gives the push effect, how the stimulation to expel out. So sodium picosulfate gives that effect to overcome from this opioid induced constipation. Next, respiratory depression. If we see the respiratory depression, so again one more question, in which level I should tell somebody is having respiratory depression? Respiratory rate at what level it will reduce, and I'll tell that the patient is going to develop respiratory depression. Please put it in the chat box. कितना कम होना चाहिए? How much of respiratory rate we will consider as a respiratory depression? So some of the Okay, now you are confused. So some of the books it gives that 8 breath per minute, some books it gives that 10 breath per minute. But better to be with the 10 breath per minute, not to wait for 8 breath per minute, otherwise it will be very late for us. So if you are giving or we are giving to any patient the first time opioid or increasing the dose, and after increasing the dose we are giving first or second dose, and immediately the patient respiratory rate is decreasing up to 10 breath per minute, immediately we should take the action or we should try to reverse the process. That is one. If the patient is already on the same dose for a longer period of time, maybe for 10-15 days, now the patient respiratory rate is decreasing, there is no point of hold the dose or reduce the dose, because it's the patient requirement. So if we hold the dose, because it may be happening because of the end of life condition, because of the disease condition or other things maybe. So we need to differentiate little bit. U means euphoria. Euphoria is the excessive feeling of happiness, and urinary retention, of course. So if the patient have the CKD or chronic kidney disease history, we have that modified dose, kidney safe modified dose, or we may switch to tramadol or fentanyl in the same time. We can either switch to the opioid or we can give the modified dose of morphine. Next, meiosis or myoclonus. Meiosis is the pinpoint of the pupil of the eyeball, and myoclonus is the tonic-clonic jerking. But it is not the generalized tonic-clonic jerking. Generalized seizure में क्या होता है? When the patient is having generalized seizure, patient will have aura, patient will not having any orientation to the time place person, but here myoclonus, because of opioid, patient will have the full orientation, but still there will be jerky movement. So these are the adverse effect of opioids, and some of them like constipation and respiratory depression is considered, and sedation is considered as a main side effect of opioids. How to overcome from the side effects? So I have told you that we never make the or target to make the patient's pain zero. It always most bearable condition. If it is 10 by 10 or 9 by 10 in numerical rating scale, our target is to make 4 by 10 or 3 by 10. It's never to make zero. If because of some reasons it happens that okay, patient develops side effect and we have find it out, so naloxone is the drug of choice which reverse the process of opioid. So naloxone starts working in 2 to 5 minutes after administration. Peak action comes in 60 minutes and 90 minutes, and it takes 30 to 90 minutes to overcome from the opioid induced side effects. So thank you so much. If you have any questions, the panel is open now. Thank you so much once again.
Dear participant, if you have any doubts, please put it in chat box. Otherwise, you can unmute your mic. Is there any doubts?
No, ma'am.
No doubts as the different question. Either you have understood
Understood.
everything or you have not understood anything. Either I am very good or I am not good at all. But I tried to make very simple so that uh,
No, it's
like
very good actually.
you can
It's
catch.
easy to understand.
It's a combination of 8 new message.
Everyone say thank you.
Everyone is thank you.
Very good,
Thank you
sir.
so much.
Easy to understand.
But if you do not have any question, I have one question.
Ask, please.
Okay. I have one question that I think everyone have encountered this Fortuin and Phenergan. Yes. Fortuin and Phenergan basically given to the post-operative condition to reduce pain and induce sleep. Why Fortuin and Phenergan is not using in pain clinic in palliative care? This is my question. Anyone is there? Can give an answer? This question you supposed to ask me. So the answer is Fortuin Phenergan. Fortuin is a strong opioid, of course, but it works on not on mu receptor. It works on kappa receptor. And kappa receptor हमारे बॉडी में इतना ज्यादा नहीं है. That is first. We do not have that much of kappa receptor. That is one. Second is kappa receptor के ऊपर if we give any medication works on kappa receptor for longer period of time, it can cause kappa stimulation, and kappa stimulation can leads to dysphoria. And because of that, Fortuin Phenergan Fortuin is not widely using in pain clinic. You will never seen any Fortuin used in pain clinic because of this reason that Fortuin cause kappa stimulation and dysphoria. Because of that, never ever we use Fortuin in pain clinic. Thank you so much. I'll be sharing my slides to yes, Hannah, and then of course there is little bit of photos are there, so I'll just omit those things and I'll just send it to you maybe tomorrow or day after tomorrow. So you can share those things to even participants. They will get little bit of idea. But actually, I'd never believe on sharing the slides because it's like my mom cooks something very good for me. If she gives, if she tell me, I can cook, but it will be not like my mom. Ingredients will be same, everything is same, but still taste will not be like her. So that's why if we give slides, there is no point of giving the slides. If you listen, then it will be more helpful. Somebody's slide will not help you at all. But anyway, you can learn something from this slide. So that's why I will be definitely sharing it with you. Thank you so much. Thank you,
Thank you.
Sparsh Hospice.
Thank you, Sudeep. It is a wonderful session, actually. Thank you so much.
Thank you.
Thank you, sir.
You are most welcome.
Sir, thank you for your insightful session, and we can wrap it up for today. And thank you, participants. You can leave now.